All right, well, good afternoon. It is almost 4. My name is Dina Pimenova. I'm the Senior Project Coordinator for the NYU Langone Community Health Worker Research and Resource Center, housed in the Department of Population Health at the NYU School of Medicine and supported by the NYU Langone Community Service Plan. On behalf of the CHWRRC and our co-sponsors, I want to welcome you to the second and final panel of the day of our second CHW Innovation Summit with a focus on new frontiers for establishing a health equity workforce. Next slide, please. A little housekeeping before we get started. Due to the nature of this being a Zoom webinar, everyone is on mute. To enable or disable closed captioning, select live transcript at the bottom of the screen. The chat box is open for comments and sharing of resources. Please make sure to select everyone and not just hosts and panelists when using this feature. Please use the Q&A box to submit questions to the speaker. We will have time to answer as many questions as we can during the Q&A portion. The slides and the recording will be made available at a later date. And lastly, please be sure to complete the survey at the end of the session. Next slide. Before I pass it on to our panelists today, I'd like to give you a quick preview of what to expect tomorrow. We will begin our day at 1 o'clock. Please note that due to an unforeseen scheduling conflict, Denise Octavia-Smith will not be able to provide the keynote. In her place, we are thrilled to welcome Romana Rabbani, a current doctoral student in health policy and management at the University of North Carolina at Chapel Hill, co-chair for the APHA CHW Section Policy Committee, and co-founder of the Community Healing Through Activism and Strategic Mobilization CHASM organization. The third and final panel of our summit tomorrow afternoon will feature CHWs and researchers who will discuss their perspectives on what impact means for CHW programs and how it's defined, facilitators and barriers to impact, the role of trust, communication, and working conditions, as well as the different measurement methods and tools their projects utilize. We hope you will join us for as many of these panels as you can. The registration links are being shared in the chat box, as well as the speaker bios. And now I will pass it on to Dr. Duncan Morrow.
Good afternoon, everybody. My name is Duncan. I am an internist pediatrician and an epidemiologist, and I serve as the Assistant Commissioner for the Bureau of Equitable Health Systems at the New York City Health Department. And it's really an incredible honor for me to serve as your moderator today. I hope everyone is able to take a few breaths and check in and attend to this moment where we're talking about community health workers and the extraordinary work that community health workers do in New York City, around this country and around the world, and specifically with respect to COVID-19 here. I'm going to start with Ernesto Fania, who I have had the pleasure and honor of working with. He's one of my many spirit guides here at the health department. He presently serves as the executive director of community healthcare support at the Bureau of Equitable Health Systems. And in that role, he leads efforts to engage and support community providers with quality improvement goals. His team provides technical assistance with electronic health records and facilitates changes to patient care flows using small rapid cycles of change to achieve objectives. Ernesto's team also works with over 400 practices on quality improvement initiatives that focus on diabetes, hypertension, smoking cessation, healthcare workforce development, and connecting patients to social needs. He is a graduate of the amazing MPA program at Metropolitan College of New York, and he's he's had an extraordinary career, including as a community health worker at one point in his career. So with that, I'll turn it over to Ernesto.
Thank you for that introduction, Duncan. I really appreciate it. Good afternoon, everyone. It's an absolute pleasure to be here with you today. I hope that you've enjoyed the summit to this point. I'm going to briefly provide an overview of some of the work that we at the Bureau of Equitable Health Systems was able to implement through Public Health Corps as part of our COVID-19 response. So through Public Health Corps, or PHCs, I'll refer throughout this conversation, the Bureau of Equitable Health Systems was able to deploy community health workers into the primary care setting, as I mentioned, as part of our COVID response. The majority of our CHW cohort was deployed to federally qualified health centers, or FQHCs, that were administering the COVID-19 vaccines. We were also able to deploy a smaller number of CHWs to independent primary care sites that were located within the Public Health Corps neighborhoods. So the primary goal of our Public Health Corps programming within the clinic setting was to provide access to vaccines. An additional goal of the program was to make sure that the residents where these FQHCs were located in these communities, to make sure that they were connected to medical care and social services that would help them lead healthier lives over the long haul. Leading some of that work was our wonderful cohort of community health workers. The FQHCs were providing COVID-19 vaccines and engaged in community health worker-led screenings around chronic illness, like hypertension, diabetes, and the CHWs were also screening for social needs and making referrals to address identified needs when appropriate. So that's kind of an overview of the FQHC work. And then in the small practices, so these are generally one provider and maybe a handful of staff offices. The CHWs were focused on administering SDOH, social determinant of health screenings, to patients with hypertension and diabetes. So the difference between the FQHC and the small practice is that working in a smaller, more intimate setting like an independent practice allowed for a more case management focused approach. And the CHWs working with the small practices worked with a caseload of 30 patients at a time. The CHWs and staff from our bureau would work together to provide a monthly update report to providers at each practice, just to let them know which patients were being connected to services and how the progress was going. We are very fortunate to have 2 CHWs on today's panel who worked in each type of primary care setting. And I'm really looking forward to hearing their and the other CHWs on the panel's perspectives. Thank you, and I will pass it back to Duncan.
Thank you so much, Ernesto, for that. Our next speaker is going to be Rogelio Ocosto. And let me say a few words about Rogelio. Rogelio has been creating connections between vulnerable populations and healthcare providers in NYC since March 11th, 2020, when the pandemic officially began in NYC. He started as a volunteer at vaccination centers, then began working for Vax for All, and had enormous responsibility of vaccinating NYC residents. As a result of working for Vax for All, he started studying for a CHW position through Lehman College. And Rogelio now works as a CHW, helping patients navigate healthcare and social service systems through community outreach and chronic disease prevention. So thank you so much, Rogelio, and take it away.
Thank you, Duncan, and thank you, Ernesto, and thank you all. It's a pleasure to be here. My name's Rogelio. I work for a faith-based primary care center on Staten Island. And it's been very interesting because of the diversity of ethnicities and religions that are in that area and come to our office. We have 2 offices that happen to be located near a CVS, which most of the patients get their prescriptions, but we also happen to be across the street from a fitness center, which I belong to, and I often run into the patients there. And many of them don't know when we start up conversation outside of the clinical setting that we have a nutritionist on board, and whatever their particular issue is, whether it be diabetes, blood thinners, or what have you, it's great to have them meet up with the nutritionist, since they already have these fitness goals in mind, and help them further along in the process. And then I'm, constantly running into them at the gym, and we just start these very interesting conversations, and seeing them progress in their fitness goals and their health. And then I'm able to introduce them to other services that we have if they need it. I could go on and on with personal stories, but I know our time is limited here, but that's one of the things that stood out to me the most working for the Beacon Christian Community Health Center. Thank you.
Thank you so much, Rogelio. I again really appreciate your being here and sharing your stories, and look forward to more discussion in our panel. So the next person I will introduce is Be Uma, who is a community health worker and another member of the NYC Public Health Corps. She currently works with chronically ill patients to improve social determinants of health for the better and more equitable health outcomes. Bay is an immigrant originally from Kenya and currently lives in Upper Manhattan. So again, such an honor for you to be with us today, Bay. So please share.
Thank you so much, Duncan, and everyone for the warm welcome. My name is Bay. I am a community health worker, and currently I work in a primary care setting. So I don't work in a large hospital setting. I don't work in a clinic. I work as part of a pilot program to actually reach patients in a primary care setting. Because guess what? Patients in a primary care setting who may not be going to the hospital, who may not like going to the clinic, but who have a trusted relationship with a local neighborhood doctor, they still need access to resources and services as well. So I'm happy to be part of the Fund for Public Health and Department of Health public-private partnership. I'm happy to be part of this pilot. And I'm really happy that patients in the private care setting, their response is, wow, I didn't know community health workers come to the doctor's offices as well. And so they're excited that community health workers are expanding in the sites that they're in. I think in the other panel, somebody talked about hopefully expanding community health work to even schools. So this is a new initiative that I'm happy to be part of. Prior to working in the Public Health Corps, prior to working as a community health worker, I was, like Rogelio, part of the Vax for All Corps, the pandemic response team. So I do love that the foundation for my work is rooted in COVID-19 virus awareness and education, because not only did we work in the vaccination sites and COVID testing sites that were run by the Department of Health, but we also were trained to work in community outreach. And in a sense, we were community health workers on the street. So we were able to engage community members in areas where they lived, worked, and played. And in large urban cities like New York City, I love that we are reaching out to patients, not just in a traditional setting like in a hospital, where they might have a social worker 24/7, but also on the streets, and also currently where I serve in a primary care setting. One thing I do love is patients are learning the connection between access to social services and healthcare, right? If a patient who uses a mobility device such as a walker cannot get to their medical appointments, guess what? Their healthcare is going to suffer. And so now patients are recognizing that social needs screening is very crucial for optimum healthcare. That there are some diabetic patients who come in and they have this chronic illness, diabetes, and they say, well, I can't take my insulin like the doctor wants me to take because I don't have access to food. That for a community health worker is an emergency. And thank goodness there are local community-based organizations that I have been to personally and I have made connections with, where I can just, send an email to the director and say, hey, I have somebody coming. I know it's 4 o'clock when you normally close, but can I send somebody over so they can get a bag of food for the week? This is a local food pantry, but it's also a center where patients can sign up for SNAP, right? Food benefits, and they can also sign up for senior services and senior resources. So part of being a community health worker is learning to make connections in the community, for optimum enjoyment of my patients. And again, because the patients understand social needs when they're addressed actually help in healthcare. So I really do enjoy what I'm doing. My goal is to grow. I enjoy, my favorite part of the job is the professional development. I used to be a home health aide, and as a home health aide, you are talking to patients, you're going into patients' houses, and you're a community health worker for one person. But as a community health worker in a primary care setting, I get to speak to many patients. But I'm not given this task without tools. I really do love the Fund for Public Health and the Department of Health and Mental Hygiene. How they're devoted to professional development. So community health workers have irregular training, regular education, updates on healthcare, updates on language, updates on cultural awareness, and teaching us how to be culturally humble so that we can better serve our communities. I used to live in Harlem, and now I live in Upper Manhattan, so just a little bit north of Harlem, still in Manhattan, in New York City. And so I'm familiar with some of these community-based organizations, and I'm happy that one aspect of being a community health worker is that peer-to-peer providing of service. Somebody saw me and said, you know what, Bay has enough lived experience. Bay has been to a homeless shelter. Bay has been to the SNAP office. Bay has been to the HRA office. And so Bay has that lived experience that she can help other members of her community to develop and grow and have better healthcare outcomes. So I do love that other aspect of using those in the community who have overcome to help others in the community who have that lived experience. So, I really want to make sure that as a trusted messenger in the community, I have the integrity to continue to work so that I can uphold the patients, so I can empower the patients, so I can let them know they do have control in improving their healthcare and improving their lives. So I'm very excited to continue my work as a community health worker and to grow. Thank you, everyone.
Wow, thank you for that, Bay. Just such an inspiring career journey, and your passion for growth really resonates, and I think I hope we can return to that in the panel discussion a bit. Our next panelist is Dr. Simbo Ige, who is just somebody I am so blessed to have as a colleague, and has already taught me so much here at the health department. She's the assistant commissioner for the Bureau of Health Equity Capacity Building here at the NYC Health Department. And in this role, she works to increase capacity and readiness of community partners and other institutions to address health inequities across the city. She also leads COVID-19 community and partner engagement efforts to ensure equity and access and uptake of vaccines for all New Yorkers. And I would just say she is also just a fierce advocate and an amazing champion of workforce issues and of health equity, and just amidst all of our challenges as a health department to actually do community engagement and to center health equity in all we do, somebody who is relentless. So thank you, Dr. Simbo, for joining.
Thank you, Duncan, and thank you, everyone. I am always excited when we have conversations about health equity and when we have conversations about community engagement. And to just hear the speakers and the community health workers go before me just gives me joy. So public health is health for all people, by all people. For too long, we have thought about health as something we get from hospitals or something that can be provided by just a few special people. And we have been reimagining public health as a space where everyone has a role. And we have really emphasized the role that those who are from the community can play in helping other community members achieve their health goals. And I like to say to people that health is more than the absence of sickness. So the fact that you're not sick doesn't mean you're healthy. Health is mental well-being, physical well-being, emotional well-being, and now there's even spiritual, economic well-being that have been incorporated. So how can people be healthy without support from their community? It is impossible. So we know for a fact that the social circumstances, including the relationships that people have, determine how well they feel or their well-being. So we know that we are not able to do this work without our community partners. We're not able to do the work without our community health workers. So in the midst of COVID, one of the biggest threats that we had, we wanted to build and leverage on that infrastructure, that community infrastructure, to ensure that New Yorkers could get the resources, could get the information that they needed to be able to stay healthy. And we have had remarkable success. We have demonstrated over and over again that the public health workforce, especially the community-based public health workforce, is so vital to protecting and promoting the health of New Yorkers. So I am looking forward to the conversation today. The partnership we have had has involved community-based organizations, almost 100 community-based organizations. And these community-based organizations have brought on over 2,600 community health workers all over the city. We have worked in over 84 zip codes in the city. And we are very excited about the work that the community health workers have done to date in all areas. COVID, helping to connect people to resources, helping to connect the community to us, and helping us learn how to do public health better. So thank you for having me, and I look forward to learning more from you all.
Thank you, Dr. Simbo. And our next speaker is Trinity Torres, who joined AIRnyc in 2022. Trinity graduated from the University of Buffalo with a degree in public health. During college, she developed a strong passion for her major as it allowed her to use her interest in health while also targeting the needs of community. Trinity moved to the Bronx back in 2006, where she was raised, attended school, and worked. Throughout the year, she developed a connection with the community and understands many of the disparities that the residents face. She is looking forward to using her position as a community health worker to help aid the same community she has grown up in by educating, protecting, and addressing many of the health concerns individuals and their families face. And again, thank you so much, Trinity, for being here. You're an inspiration for us.
Thank you. Hello, everyone. My name is Trinity Torres. I am a CHW at AIRnyc. I'm a part of the Public Health Corps, and we focus on the COVID disparity grant. We try to bring many resources to the community regarding vaccines, boosters, and try to just alleviate a lot of the misinformation surrounding COVID. Next slide. So I'm going to jump into a background about AIRnyc. We were established back in 2001 as a community-based participatory research project, and our main focus at the time was asthma-related care. Since then, we have grown and become a community-based organization that has really worked to improve the disparities that many individuals face. Not only do we focus on asthma anymore, we focus on many different health outcomes, chronic health issues, and social needs. And we work hand in within the community. And this really just gives us an ability to properly understand the ways that individuals interact with the community and many of the resources that they're looking for to address their needs. Next slide. So since we've started, we've built many partnerships. Many of these partnerships have allowed us to create programs that help to address many health outcomes. And some of the approaches that these programs consist of are care gaps and return to care, social needs screening and navigation, chronic condition self-management. We also do on-the-ground work through PHC, MAP, street outreach and education, and we focus on telehealth, equity, and literacy in obstetric and infant health. Next slide, please. So our CHWs really work to build strong relationships with the community members or clients that they engage with every day. Some of the ways that we really connect with these individuals are through different methods such as outreach, engagement, coordination, navigation, facilitation, screening, coaching, and education. As for PHC specifically, a main way that we're able to connect with the community is through outreach, navigation, and educational sessions. This has really allowed us to really understand what it is that community members are looking for, many of the barriers that they're facing, and how to really address the needs that they're looking for. And we really just pride ourselves in being able to provide optimal care to these individuals who are really seeking this assistance. And just for that reason, we provide many different services, which can include virtual and in-person engagement. So we call individuals, we reach out to them through text messages or have like virtual meetings with them to really just hear their stories and try to connect them to resources that can address their situation. We also connect them to different resources regarding medical and social care. So for PHC specifically, we do a lot of food referrals. So if individuals are looking for food insecurity resources like WIC or SNAP, we try to connect them with organizations that can help them with that. People who are immigrants, they're looking for legal services, so we try to connect them with different organizations regarding that as well. And we also focus on telehealth navigation support. So we know that with the changes in healthcare, technology has been advancing and many people may not be up to date with using these different sources. So we try to help them so that they're still able to receive the best care for their health. We also build accountable community social care networks. We provide PPE such as like masks, hand sanitizer, also COVID test kits, And we also have educational sessions with community members on different topics. This can be in person or virtual. And some of the most successful presentations that we have been on things such as mental health or COVID-19, more so like the bivalent boosters that many people do not know about. So we just really try to advocate and many topics that people may not be that aware of or may have a lot of misinformation surrounding. Next slide. So I want to thank everyone today for listening to my presentation. I hope that all of this information was very insightful to you all, and I look forward to being able to get more feedback about myself as a community health worker. So thank you.
Thank you so much, Trinity. I'm going to start off with a question for the Trinity and Rogelio and Bay. Maybe just building off of something that Bay was talking about regarding regarding growth and sort of an impact as CHWs. What if you might, whoever sort of wants to take this one first, if you might just share a little bit more about sort of a story of personal growth and public health impact that that from your time over these last several months.
Well, I've found, and this is sort of a reaction to what Dr. Simbo said about health being not the lack of sickness. And it made me realize how much preventative health is more important than treating symptoms. And I think that a lot of people come to the primary care center because they have symptoms. So educating them, once again, you know, I mentioned the nutritionist, but educating them on things that they can do to prevent it. Mental health, we just opened up a psychologist's office at Beacon, and you know, a lot of people don't think they need that, but I've met people when you bring it up that you know, I had a patient that said, look, I just want to talk to somebody, and they didn't know what that meant in terms of therapy. So I personally, I think my viewpoint has changed since I started into making this more preventative. And one more thing is I run into a lot of people, friends also, that are suffering from long COVID, and they just can't get a grip on that. And what they can do to feel better. And once again, health, as Dr. Simbo said, that it's much more than treating symptoms. And I think that's really the message we have to get out. Thank you.
Yeah, I don't know if Trinity or Bay, you wanted to add to that or share other related stories. Oh, go ahead, Bay.
Sure, absolutely. When it comes to personal growth, I get a model in and where I work now that I can use with my patients. I'm immersed in a community where facts are king. I'm immersed in a community where a professional community, right? My colleagues, my supervisors, where we don't engage in dangerous echo chambers. I'm immersed in a community where we don't repeat what we heard on the street. And I think as employees, we're also human. We're also patients. And at one point or another, I think I engaged in that. Oh my gosh, I heard, Bill Gates is putting chips in the vaccine. I mean, obviously, I didn't believe in something like that, but I think we engaged in a kind of talk that was based on facts that actually hurt the healthcare community and affected patients getting the care they needed. This is going back to before COVID time. Now, I hear my church, I hear something related to health. It's not a fact. I think it's but healthcare community, I have to sort of
Bay, we're losing, so we're losing your audio here. Oh, yeah.
Okay. What I'll do while somebody else goes is
But-
maybe I'll type in the chat.
Okay, but that, I think we caught some of that. Yeah, I just wanted to see if Trinity, if you wanted to share on that question, and then we can, then there's a question actually that came up in the chat that I think I'll pose to the group.
Yes, so I would say personally, we've experienced with working in the community, we're able to build a lot of trust within the community. They see us every day and they look to us to be able to share their stories. I feel like this has given us a great platform to be able to connect and really understand what it is that community members are looking for to better their situations, and really just like spread the awareness on these problems on a bigger platform. So I would say like that is really what has given me like such a great experience with being a CHW.
Thank you so much for that, Trinity. I want to ask one more question that build off something that Bay shared, and then we'll jump to one of the questions about workforce in from the Q&A. And again, audience members, please do keep putting stuff in the chat or in the Q&A. This question about the information environment, which is, our communities are really inundated with an enormous amount of information that that are true and false and everywhere in between about COVID and about other health topics in the world, and we were curious about sharing. Are there things that you're seeing as CHWs that are particularly salient with respect to messages about COVID and vaccination, and are there things that we as a public health community, we as a city government could be doing better to help you all get your message across? And again, Trinity or Bay or Rogelio, please.
Well,
Go
I'm sorry.
ahead. No, it's okay. Go ahead.
Once again, there's that stigma attached to COVID vaccines, boosters. As Trinity said, gaining trust and building that trust. And that doesn't take one visit. People have to get to know you. And I think being at my location for a year and being in the neighborhood, people see me around, I see them around. And the patients that come back to the clinic, once you engage them in that conversation, sometimes they have a change of mind and they will get the booster, but there are, a lot of stigmas attached to it. And within certain demographics, word spreads like wildfire. And so I think that's one of the challenging things at this point in our COVID vaccination history.
And to add to what Rogelio said, I would say that age actually plays a huge role into how the message gets across, mainly because I've seen firsthand how elderly people are more receptive to getting more information surrounding COVID-19. But when we try to talk to younger generations, young adults or teenagers, they don't really care too much to hear about it. And they often think of it as such a negative thing, which is fine, but we can't really get that message across. And it's hard to get that message across when there are so many different forms of communication surrounding COVID, especially politically. We see how the views on COVID have been changing. There's not been a lot of mandates. Everything is changing. So it's kind of hard to really back us up on what we're trying to spread within the community, because people are getting a whole bunch of different mixed messages surrounding COVID. So I would say when it comes to really addressing ways to support us, it would be great to have more advertisement for people who community members really look up to, that can represent whatever messages that we're trying to get across, such as us ourselves, because we deal with these individuals every day and they look at us as trusted members within their community. So that would be great.
What type of advertising do you think, Trinity?
Well, honestly, I was thinking, I know how it could be posters, things that people see every day, at the bus stop or in the train station, because people are constantly using public transportation and everyone sees them every day. So things like that would be great ways to get the message across.
Yeah, we actually produced a cable television commercial in English and Spanish. And it was amazing how many people responded to that. So that's expensive, but we did it on local cable.
That's great. Thanks so much for that. I wanted to just pivot the conversation a bit around workforce development, which is something that I and a number of colleagues in this space are particularly passionate about, and we're mindful that we as a society and city and state government and federal governments have really not continue to not invest sufficiently in the community health workforce, its developments and salary, benefits, working conditions, career growth, et cetera. There's a question from Joanna Davis in the Q&A that I'd love to hear Ernesto or Simbo your responses to, which is, do CHW employing organizations plan to retain the CHW workforce, and if so, how will they continue to fund them?
I can jump in. As a society, when there is an emergency, there are a lot of resources that are deployed. So an emergency means that we are facing a circumstance or situation that is beyond our capacity to manage alone. And so we call for reinforcement, and federal funding pours in, and city and state funding and resources are deployed. And that's what happened with COVID. We had an unprecedented pandemic that was impacting everyone. And so there were tons of resources deployed, and we had the opportunity to demonstrate how a community-based public health workforce is so essential. Now, outside of an emergency, under blue skies, how can we leverage the same infrastructure and encourage continued support for the community-based public health workforce? That is a question we're still wrestling with. Many of the organizations we partner with to respond to COVID is a time-limited kind of partnership that is funded through federal dollars. Those federal dollars are for the emergency and will expire at some point. Currently, we're still exploring options for routine beyond an emergency, is what I mean by routine, context where we can continue to have community health workers and community-based organizations as part of our public health workforce for the long term. We have already seen that this is vital to helping to get information to our communities. So we are committed to ensuring that that kind of infrastructure is supported. But at the moment, I cannot guarantee that we have commitment yet for the funding outside of COVID. And Ernesto can say a little more.
Sure, thank you. We certainly have momentum, and I think it's an opportunity to see some of that momentum, to have some of the conversations that Dr. Ige just described. CHW, that's nothing new, right? Community health workers have been around for forever. I was one over 20 years ago. I think that through the emergency response, as I said, we got people's attention. The impact is apparent. So it's shifting this perception that a community health worker is an accessory to emergency funding or a grant, and really normalizing placement. So additional conversations need to happen around reimbursement mechanisms for services. At the end of the day, the work that you all are doing are keeping people healthier and out of the hospital. And in the grander scheme of things, saving dollars from that perspective.
Yeah, and I just wanted to see if Rogelio or Bay or Trinity, if you want to add anything to that, to what Ernesto and Simbo shared regarding workforce development and the field of community health workers. Okay. Yeah, and I see in the chat. Thank you, Joanna. I mean, I certainly, I think we all recognize that this is really a national and global struggle to make the moral and public health impact case for really investing in a well-supported community health workforce that both saves lives and helps communities be healthier. So I'm going to I want to pose one other question here. So that was posed at in registration around technology. And I'll just read the question, which is, how can the CHW models integrate technology and data sharing in order to support a closed loop infrastructure, not just laying out the platform for them, but enabling them to be technologically savvy in order to use the tools effectively? So I'd be curious if any of the panelists want to share thoughts on CHWs and technology, and perhaps your experiences with different tools, and what we might be able to do to improve and build those platforms.
I mean, in terms of using NowPow, everybody knows what that is. I personally love it and can navigate it without any problem. I find it's overwhelming for certain patients. You know, I happened to run into a patient who needed housing, was interested in therapy, did not have a doctor, and you know, the list went on. And she had just recently got a government phone, and she was overwhelmed by the links that I sent to her, and really didn't quite understand how to prioritize herself, I guess, in terms of, you know, the information I was able to send to her. So I guess finding a way that we can streamline that technology, the knowledge of the technology, I guess, with the patients would help. So they understand exactly what we're doing. Does that make sense?
I just have a question for Rogelio. What was the age of the patient? Was it a senior citizen?
I'm sorry, I didn't quite hear that.
Was the patient a senior citizen?
I still didn't. I'm sorry, Bay.
It's breaking up.
Bay's question was the patient an elder or a senior?
Middle-aged. Yeah, middle-aged. She was having a hard time of things. I actually met her also at the fitness center. She slept at the Staten Island Ferry, but bought this cheap membership, $10 a month at Planet Fitness, so she could shower. And I happened to be resting in a chair one day, and she was sitting across from me, and we started this conversation. And so I took her number, and the next time I saw her, she was pretty overwhelmed by the list. And I actually recommended that she sit down with the therapist, which she did make an appointment. And ironically, the second time I saw her, she wasn't wearing layers of clothing, and she was clean. And she seemed on the path. I saw her another time where she didn't look so good. So, you know, it's, you're never going to, you know, overcome every obstacle in one shot. And maybe she needs, you know, someone needs to sit down with her and, you know, help her plan out all of these things that she needs.
Actually, wanted to share a thought to support what Roger just mentioned and answer the first part about integrating the CHW model into technology. I think when we talk about technology and healthcare and social services, we have to be careful because sometimes we create a great app or a platform, and what ends up happening is that the very people that this platform or technology was created to support, they end up getting left behind, right? So I think a way to integrate CHWs in that is for them to act as a bridge, as Rogelio described, right? Be that bridge, show the patients how to use this technology. We see this all the time when we're working with clinics, super important. Make sure that they're competent, and then it'll be used as it was designed to be used.
Yeah, and I'll add to that from the perspective of the closed loop referral and getting CHWs on board. Like with any new practice, it takes a while for people to get on board. Closed loop referral can be challenging because it's not intuitive. When you're having a conversation with a patient, it's hard for you to say, oh, give me a moment. I'm typing on the computer, I'm pulling some information in. It's just not natural. It breaks that connection you have with the client. And so it's a little tricky, to be sincere. And to get people on board using that technology, we need to be able to do more in demonstrating the value add and to showcase how it makes the work easier and rather than complicating the process. The utility in having all of the resources in one place is that you don't have to put it all in your head. You don't have to hand people different sheets of paper. You'll be able to if they get the services or not. But it takes a while for people to catch onto it or to actually integrate it into their workflow in a way that is seamless and not distractive. So that takes a lot of encouragement and also being able to demonstrate the value add. With any technology, even with us in the Department of Health, when we introduce new technology, it takes a while for people to appreciate or get on board. But with continuous demonstration of how useful the tool is and how it helps us to achieve better care for the patients we're trying to serve, I think we have had more people using now POW and those referral tracking processes than before.
I just want to jump in really quickly. Personally, I would say that because we're in the fields a lot of times, so we don't have like certain platforms that we use, but we do, when we do refer people to like resources, we try to give them handouts so that because we know that some people do not use technology or they don't have like emails and things like that, because we've come across that where we've tried to do certain Google links and we want them to sign up for things and individuals say they don't have emails or things like that. So it makes it a little bit harder. But when we do try to refer them to other resources that we don't have on hand, we try to just demonstrate in front of them. So like we'll use our own phone and show them a walkthrough of a website that we're trying to display to them and how to use it and what they can do in order to find what it is that they're looking for. So it can just make it a little bit more easier for them when they try to do it on their own. And we also try to ask them like if they have anyone in their household that does use technology, if they could help them, because we know that it can be harder for some people to use technology. So we want to be able to, if we do give them that information, if they do run into some issues, they have someone at home that can help them if they need help.
And that's where follow-up is so important also with these patients, to make sure they did understand it. They did make that appointment.
There's a really excellent question in the chat from Alan Keller. Are we utilizing as members of the CHW workforce immigrant health professionals, including physicians, trained in their home countries who aren't licensed in the US? What opportunities and what barriers are to this? And again, I sort of open up to any of the panelists.
I don't think I quite understood that. So are these licensed professionals in the US or licensed in another country?
I can say something about that. It's a world I'm very familiar with. So there are foreign medical graduates, people who have studied medicine in different countries, who then come to the United States and they have to be licensed to work in the United States. What opportunities are there for them? A number of opportunities depending on the individual and where they would like to be. Medicine is very highly regulated, and there are many reasons for that. Disease profiles vary by country. The kind of diseases you will see in certain countries may not be the same that you'll see here. The processes are different, the protocols are different. So in every country, there is a process to ascertain that if anyone who's going to be a medical practitioner understands the disease profile, understands the protocols for that particular country. So one pathway is for such people to, go through the licensing process if they want to be in clinical practice and seeing patients, to be sure that they are caught up to date with the practices here. For those who don't have to see clinical patients, there are other pathways, like in public health. Public health, your medical background is very useful. Understanding of public health will be required, but that's also another pathway where you're not necessarily seeing patients, but you are contributing to health improvement at a population level, not one-on-one patients. And then there's also the education field, where you can be a teacher or faculty to others who are learning to be providers. So those are some options that are available. It will depend on the individual and the areas of interest, but often when you're moving to a new country, it may require additional education and licensing to be able to practice in that new context.
Yeah, I just wanted to see if there's any other additions to that question, and maybe even more broadly about how we engage immigrant professionals and immigrant community members in the work of community health workers.
I would say that when it comes to individuals who are seeking immigration services, we try to find like places that can actually help them with that. So most of the organizations that we do know, they have individuals, well, they're actually close, or they have like an understanding relationship of what it is that these individuals are going through, so that they can actually help them based on their experiences.
Okay, thank you for those questions. I think we have about we might have time for maybe one more question round, and I think I'll shift it to sort of evaluation, and this relates a bit to what we were talking about before with how do we make the impact case to the public, to elected officials, to policymakers. But you know, and maybe this might be for Simbo and Ernesto. Just maybe if you might describe some of the current efforts, whether within the city and public health corps or outside of it, to evaluate CHW programs, and what are some of the kind of key considerations for evaluating these programs?
Yeah, I can start. Yeah, so we're always looking to improve on any implementation that we do. So we've been working with our internal evaluation teams and external partners to really drill down and identify what has worked in the last year, what could we improve on in future iterations. And an example of that is the way we started with CHW screenings in the small practice setting. We were basically just screening patients that were there for an appointment. There was phone outreach, but it was just, okay, this is your need. Here's a number to call. Here you go. There was no referral loop closing. For the second iteration of that specific pilot, the one that Bay's working on, we approached it with a more case management centric idea in mind. So we're really, for lack of a better term, hand-holding these patients from the initial assessment to when the needs have been met, and reassessing every couple of months. It's really important for us at DOH to really know what matters to our partners who we're implementing these programs at, but then also to be inclusive of the workforce, the community health workers, how they feel things are going, where we can improve, what do they need in terms of support to continue this work into the future. So in order to enhance that process, we've been having monthly listening sessions. You know, we really need to get away from this top-down program design and really be inclusive of the people that we're serving, the partners that we're working with, and the workforce.
I just want to add, I would say that the listening sessions have actually been very helpful, because this has given us the opportunity to really like hear the voices of everyone within the community. We've actually heard like a lot of views on how people feel on safety, on how people feel about COVID, about how people feel when it comes to whether or not they're getting the proper financial resources. Like, there's been so much that we've been able to understand about the community that I feel like this has given us the ability to share back, so that they can see what it is that people within the South Bronx are looking for, what troubles they're facing, and how they want it to be addressed, because otherwise we're not really going to be able to understand that. So just getting that firsthand interaction with them, it's been really beneficial.
And I will add, so evaluation is something that is really important. When we are trying to seek funding, people want to know that we're using taxpayers' money, dollars appropriately, and that what we're investing it on is useful and helping us to move towards whatever goal that we have stated. So community health workforce, there are many different studies that have been done to show how valuable they are. That is not in contention. At different times, people want to see how community health workers help to improve patient outcomes. So if you're working in a hospital, we're bringing in a community health worker because we have identified a need that the patient has that the current workforce may not be equipped or not have the bandwidth to handle. So we brought reinforcement. And we have brought in people who understand the patient we're trying to reach, who can communicate with them, who are patient and culturally competent to be able to accompany them on that journey. So how does that additional support help the patients in terms of the health outcomes we're trying to improve? So there are studies that have been shown to how valuable CAWs are in helping patients improve their A1C, in helping them to improve their blood pressure control, etc. Within the COVID context, we wanted to help communities understand the importance of the vaccines. We wanted people to feel comfortable and trust the vaccine so that they can make an informed decision. And we're not able to do that coming from the house outside. You know, I cannot just show up and knock on your door and say, here's a vaccine, take. You don't know me. But if it's someone from your community, someone that looks like you, speaks like you, and that person says, I have been vaccinated, then you wanna listen. And in that process, we have also been able to demonstrate that that approach worked. Community health workers build trust. They help people feel safer accepting the vaccines. And we have seen that through the increase in vaccination uptake in the communities where there were community health workers. So what is remaining is, can we use the same community health worker model for other situations? We have seen this work in a hospital context. We have seen it work in an emergency context. Can we use the community health worker model for other kinds of priorities at the community level and at the hospital level? So there is a lot more to be learned. And we use community health workers to help increase the rate of cancer screening. And we use community health workers to help improve the other chronic disease prevention in our communities. So there are many opportunities to see how working with the community health workforce can help achieve public health goals. And that's where we're hoping that in the future we can do more post-COVID to see how this can also help improve the outcomes we're interested in.
Hi, everyone. We are almost at time. Thank you so much to everyone. A sincere thank you to all of our speakers and audience members today. Such a privilege to get to hear from our CHW colleagues and champions today. I also want to thank our behind the scenes team, Dr. Amy Freeman and Sarah Hussein, who've done an incredible job keeping things running smoothly. We ask that you please complete the survey that is in the chat, and hope that you will be able to join us tomorrow for the sessions. Yes, I see that Amy put that in the chat box just now. And again, please join us tomorrow at 1 o'clock for a keynote by Rahman Rabbani, a current doctoral student in health policy and management at the University of North Carolina at Chapel Hill, co-chair for the APHA CHW Section Policy Committee and co-founder of the Community Healing Through Activism and Strategic Mobilization Organization, as well as our third and final panel of our summit tomorrow afternoon, which will feature CHWs and researchers who will discuss their perspectives on what impact means for CHW programs and how it's defined, facilitators and barriers to impact, the role of trust, communication, and working conditions, as well as the different measurement methods and tools their projects utilize. And if you attended any of the earlier sessions and missed the links for the surveys, I will be emailing those out. And again, just thank you so much to this panel, to our previous panels and the keynote speaker. Really just such a huge privilege. Thank you, everyone, and I hope you have a wonderful rest of your evening.
Thank you, everyone.
Thank you, everyone.
Thank you.
Thank you.